Good evening. It's a pleasure to introduce Federico Lavorini and Omar Usmani all together for the presentation on the choice of the inhalation device. Do they matter or no?
Thank you very much for inviting me to this meeting, and thank you to the organizing committee. And this is a joint talk with the aim to answer this question: does the choice of inhaler really matters? My answer is yes. Choice of inhalers really matters. And probably my opponent and good friend Homer tend to disagree with me.
Yeah, I do.
I do. Yeah, of course. But yeah, it's a good start. But before starting, how many of you really thinks that choice of inhalers do matters? How many hands? Only one? Two? Oh, wow. Not good for you, Homer. What do you think?
I like a bit of competition.
I like a bit of competition. Okay. So, these are presenters' disclosure. So, treatment of respiratory disease with drug inhaled through different delivery devices or inhalers has an history that dates back from Egyptian medicine more than 3,000 or 4,000 years ago. And fumigation, like this, were the first inhaler, followed by other rudimental devices such as pipes, straws, or vaporize. But I think the most important improvement was the introduction of handheld inhalers like the PMDI, the pressurized metered dose inhaler in the middle of 56, correct. And then the DPI a little bit later. Now we have more efficient inhalers, at least in terms of drug deposition, such as the soft mist inhaler and adaptive nebulizer. And this is shown by this demonstration that clearly shown that we now have efficient inhalers, at least in terms of lung deposition. But unfortunately, despite the improvement in inhaler technology, many patients do not use their inhaler in a correct manner properly, either DPI or PMDI. As you can see, this slide shows the percentage of patients with poor inhalation technique or patients who do critical errors that result in no drug inhalation at all. In a couple of studies, 90 studies from in a 35-time interval, and as you can see, it's evident that half of the patient, approximately 50% of the patient, do a mistake. So despite considerable attention by researchers to develop of new inhalers, there's no sustained improvement in the patient's ability to use the inhaler.
Yeah, but that's precisely my point. This is where evolution has got us to, devices that are really user-unfriendly. I mean, you know, a minimum of 10 steps in a device to achieve efficacy is pretty bad in 2014. And as you have commented, and again, that's the same with dry powder inhaler devices, you need an average of 7 or 8 steps. So you've got a device, you've got to have 8 or 9 steps, you know, you'd think that technology has gone far afield to allow us to actually improve the product. And this is what you've said, Federico. You get errors. You get errors because the devices are too complex to use. Any one of those errors is actually going to affect, as I will show you a little later, your admission to the ER, your healthcare utilization. And that's errors in PMDI, and there are errors in dry powder inhaler devices. They're just as bad as each other. And this is a very important study, and you will be familiar with it, but I like it because we talk about presentation to the ER because the patient didn't take their steroid or the pharmacological action and how that affects. But what we forget, I think, as clinicians is one error in your device can send your patient to the ER. And this is a nice study that was over 1,600 patients where they showed that there were errors, whether it's an MD or a dry powder inhaler device. It's quite interesting that actually you've got more errors with dry powder inhaler devices than you get with an MDI. Now, I know there have been some studies that have shown the reverse, but I've put this up because, in the UK we use MDIs and we like MDIs. But here you go. One error, just one error in that device will give you you will worsen your respiratory disease control, just one error. And one error in your device will actually lead greater visits to the emergency department, and that's a cost. So we should realize that actually you need to get the patient to not have these critical errors and be able to use these devices that are very complex in order for them to actually get the benefit that you describe. And yeah, there we go.
Okay, yes, we know this, Omar, but now you are saying that the device does not matter, but rather patient matter. And we also know when patient use inhaler in a correct manner, there is a significant difference in the lung deposition and in bronchodilation, as you elegantly shown a couple of years ago. So you are right from this point of view.
Yeah, but that's my point. Patients are important. They're more important than the device. So even with the correct inhalation technique here, your device, at best, the majority of the ones that we use in clinical practice, only give you 10, at best 15% deposition in the lung. 80% of that dose is wasted. Now, if I told you your washing machine at home required 5 times as much washing powder to do one wash, you'd all be complaining. If I told you your car engine required 5 times as much petrol just to do one journey, we'd all be complaining. So why aren't we complaining as a respiratory community when we're putting 5 times as much drug in a really inefficient device just to get 20% out in human beings with the potential for side effects? And I think as a respiratory community, we've just accepted what the pharmaceutical industry have thrown at us for 5 decades. They've come along with their new molecules, put them into really inefficient devices, and accepted us to accept those devices. And we haven't questioned this. And I think the real wake-up call was the Montreal Protocol that enforced the banning of CFC propellants and actually externally made science rethink on what the devices should be and indeed what the chemistry of the device should be.
Oh yes, Omar, but we have moved on because you said about other industry like automobiles or aircraft making more efficient product, but so also the inhaler industry has more efficient products because now we have new inhaler, new PMDIs, new more efficient PMDIs that are able to induce a more efficient lung deposition at half the dose. We have PMDI delivering smaller aerosol particle with a much higher lung deposition, and much importantly, these new devices, new PMDIs, are clinically effective at half the dose of traditional PMDIs. And again, Omar, this data comes from your study. And your results suggest that if you have a good device formulation, then the patient factor do not matter. We can see that inhaler producing particles of different size have different effect on lung deposition. And going back to the correct maneuver when using the dry powder inhaler, one of the crucial steps to correctly operate the DPI is to inhale as far as you can from the start and maintain this for as long as you can. Well, why this maneuver is required? Well, this slide shows in a schematic form what a DPI formulation looks like. The drug here is attached to a carrier, usually lactose, to formulate pellets. And it is the turbulent force induced by the patient inhalation maneuver inside the DPI that induces disaggregation of drug from the carrier. So according to this equation, the higher the inhaler resistance, the lower will be the inhalation effort due to obtain a particular turbulent energy. And since inhaler resistance differs substantially between different DPI, so the inspiratory effort needed to obtain, let's say, 4 kPa, it's quite different if you have a high resistance DPI, you need 40 liters per minute. But if you have a low resistance DPI, you need 100 liters per minute. So, in other words, patient inhalation flow is important, but also inhaler resistance is important. So inhalants does matter. And again, the DPI, according to this equation, can be classified as that. High resistance, low resistance, and high intermediate, and so on.
Okay, no, I see what you mean, resistance, yeah, but I'm, like yourself, a busy practicing clinician. I'm not going to think about resistance when I'm seeing my patient. What I'm thinking about is the patient in front of me, are they able to get the right flow in order to get some drug into their lungs? And I think if you just take this slide, very simply, you can see that you've got flow rate there. And what this slide gives many, many messages, but it just shows that the flow rate is important, irrespective of the device, in terms of achieving your deposition. And, you know, we get, what I want to know is, you've got a stable patient, they've got a respiratory rate of 12, they're going to be able to get the energy that you described. But what about an unstable patient with a respiratory rate of 20, who's having an asthmatic exacerbation? Are they able to get the energy to get that drug into their lungs? I mean, and you know, that's what matters. It's the patient that matters. And again, we get data from the pharmaceutical industry that just shows us when the patients are really stable. But I want to see data when they're unstable. COPD data when patients are unstable, when their respiratory rate is not good, or an asthmatic patient at night time when they're waking up and they want the inhaled medicine. Maybe they're not getting benefit because the device isn't good. And this is a very important study. And so this is the ACCP study that was really Myrna-Dolovich, who is really one of the doyens in aerosol science. And essentially, the conclusion is on the bottom. And the choice of the inhaler device doesn't matter if the patients are using the inhalers properly. Now, you may think, well, that's favoring you. But actually, they looked at different clinical settings. Patients using inhalers in the emergency department, patients using inhalers in the outpatient department, and different patient populations, asthma and COPD. And basically, it's really down to the patient. I mean, the patient matters more than the device matters, Federico.
Yes, Omar, I know very well the meta-analysis by Myrna-Dolovich, and from the statistical point of view, it is correct. But unfortunately, this meta-analysis has several limitations. For example, the studies included in the meta-analysis were extremely heterogeneous from a lot of several point of view about the design and the patient selection. More studies were often empowered, and the patient inhalation technique not well described, and much importantly, the majority of the studies that were included in the meta-analysis were studies aimed to compare the bronchodilator effect of the same drug inhaled through different devices. So and generally the dose used in that studies were so high, were near the top of the bronchodilator response. So the difference in response could be not reflected in a real difference in lung delivery of the drug. If you consider a different angle, a different bias, say, for example, a functional antagonist between a muscarinic and adrenergic agonist, this could be particularly suitable to evaluate differences in airway response when the same bronchodilator drug is administered through different inhalers. And we use that kind of bias a couple of years ago in a series of studies performed in asthma patients to investigate the effect of a bronchodilation induced by salbutamol in asthma patients with methacholine-induced bronchoconstriction. And the salbutamol was delivered carefully and with controlled flow and volume through the classic PMDI plus pacer, and in a randomized fashion and crossover fashion through a DPI, the discus. And what we found is shown here. Please consider the inspiratory capacity that reflect gas trapping. If the difference in the changes in an increase in inspiratory capacities is evident. But what about the FEV1, the more classic FEV1 variable? No absolute difference in absolute terms, but when we consider the bioequivalence, we found that both inhalers cannot be considered as equivalent because the PMDI was twice as efficient as the discus DPI in lung delivery of salbutamol. We found similar and stronger results as when we consider the speed of onset of a bronchodilation. The difference is evident, probably statistical, is not important. And again, we found also that the two devices cannot be considered equivalent. The same drug doses administered through different devices gave different response. I think taken together, this result strongly supported the concept that inhaler really does matter.
So randomized, controlled,
Yep.
sterile environments where there are select inclusion criteria, exclusion criteria, small patient numbers, just salbutamol. You're on the respiratory effectiveness
So you
group.
say my study have a lot of limitations.
Well, what about, so let's translate it to the real world. I mean, I'm talking about pragmatically, you have a patient there, so many devices you've shown, how am I going to decide that that patient should be on an MDI or a DPI or a nebulizer or an MDI plus a spacer?
Did you act as a reviewer for my paper?
Go.
No?
Well, the choice of the...
No, that's correct. The criticisms are correct, but now I can say that some real-life study seems to suggest, in asthma, at least in asthma, seems to suggest that inhaler device selection has a bearing on clinical asthma outcome, at least in terms of asthma control. We can find two different populations of asthma patients, and the drug was administered through a PMDIs or DPIs or different formulation of the same inhaler, but we can see different response in terms of asthma control.
Yeah, but, you know, I mean, this is the real world, though. There are 250 drug-device combinations in any formulary in any part of the world. And so, you know, we're always trying to work out which device should the patient be on. And I think the important thing here is that as doctors, we're the worst people knowing in terms of which device to give to our patients. And we're quite uncertain about inhaler use. So this was a nice study from Hanania 20 years ago. They had junior respiratory trainees, respiratory nurses, respiratory physiotherapists. They said to these three groups, the investigators, you tell us how you demonstrate these three devices to your patients. And look, the doctors came out the worst compared to the nurses and the physiotherapists. And the authors of this study concluded that actually, instruction is very important. Now, when I went through my training as a respiratory intern, I didn't have one lecture on aerosol medicine. And it's not because I'm passionate about inhalation science, but when you get taught on cystic fibrosis, COPD, asthma, I mean, inhalers are the foundation. They're the bread and butter. Whether you're an intensivist working in the ICU with nebulizers, or you're a community respiratory pediatrician trying to get your 4-year-old to use a dry powder inhaler device, or an asthma COPD person, you need to really have some training in aerosols. And this is, no, I mean, go back, look, this is what they concluded. I mean, the physios had more training than the doctors and nurses. Now, you can see the nurses had less training, but they scored higher because of their day-to-day exposure with inhalers and aerosols. So really, you know, the key question is choosing the appropriate inhaler for the patient should be based on the patient. And that's important because, look, that's what that slide I've put up. What do patients want? They want to know that you're getting efficacy, but it's efficacy in clinical trials or in real life trials may actually be the result of the actual inhaler itself. You know, we're talking about asthma control, COPD control. Are we treating the whole airways? I mean, ease of device use, convenience of the device, a dose counter. These are things that we want in these devices and patients want. And I think, you know, and that's what doctors want. Doctors also want this. And they want, in in red, feedback. They want our patients to know that they are getting that drug. And they want reduced time for teaching.
Okay, I agree. But also preference.
You agree?
Yeah, I agree. I agree in this point. But also preference and for patient preference and satisfaction may be of importance when selecting an inhaler device, but I think that some studies have shown that preference for and satisfaction with a particular inhaler is associated with some improved outcome. But to me, there are very few validated instruments available to objectively assess preference and satisfaction with an inhaler, with a particular inhaler device. And much importantly, in sponsored trials, the sponsor inhalers was always the preferred one.
Yeah, but you know, I mean, you are an author, we know, with all on this paper, and you know, look, the devices are all there on the bottom, or they're probably the result of your algorithm, but the patient's on the top, and then you've divided the patient into the conscious one, and then based it on their inspiratory flow, and that's exactly what I'm talking about. Start with the patient, see what they can do, then the choice of your inhaler device is going to be simple.
Okay, I agree with you that also patient factors are important, but you have to agree with me that inhaler, the choice of inhaler is important because you were a co-author in this editorial in which me and you write that in patients with obstructive airway disease, choice of inhaler is as critical as the choice of medication itself.
Yeah, that's controversial. Look, the choice of a new compound will be secondary to the need to choose the appropriate inhaler device for the patient.
Okay, we are finished.
Okay, all right.
No. Just a moment. Now we are at the end. What do you think? How many of you think now the choice of inhalers matters? How many? Much increased.
Non-believers.
And who disagree with this view? Ah, Professor Fabri. Historically. So these are joint conclusion. Inhalers, we believe that inhalers do matters in management of obstructive airway disease, asthma and COPD. And it's much important that not all inhalers are considered as the same, and clinicians must appreciate characteristic of each inhaler devices.
Yeah, I mean, clinicians, so this is a very expert group. They probably know all the 250 inhaler devices out there. Clinicians should select the devices that the patient can, I think, and will use effectively. And they should be trained on the proper inhaler use, and their technique should be checked, I think, at each visit. And that's not done. Study by Plaza showed that less than 25% of patients in Spain had their inhaler technique checked. And that was only published last year, and this was in over 1,500 specialist pulmonologists.
Move to the movie?
Okay, all right. So we've got some light entertainment now before dinner. So...
But as you can see, the Bond antagonist died not due to the improper technique. He was killed by, and just the last is here. Please get a look to this face, to this man. He is very sad, and why is very sad? Is it the effect of inhalers misuse or improper misuse or improper choice? No. He remembers something very different. I hope that on Saturday we will be the same results. Thank you very much.
That's all. Very much.